So I'll first start off with the definition of the trial for DESTINY-Breast11. So these were our high-risk patients, as you guys know, high-risk patients that either had a tumor over 5 centimeters or were lymph node positive. And these patients were HER2 positive early breast cancer. They could be hormone positive or hormone negative. And these patients were randomized to receive T-DXd times 4 cycles followed by THP times 4 cycles, or they received dose-dense AC followed by THP, which was standard of care in many parts of the world at the time, or patients were randomized to receive T-DXd for 8 cycles, and that arm was discontinued later on in the trial. And so the primary endpoint of that trial was looking at pathological complete response, which did come out to be a positive result. So we ended up finding out that patients had a PAT-CR rate of 67%, 61% in the hormone positive, which is not a PAT-CR rate we have seen in that population before, versus 83% in the hormone negative. So very exciting early trend towards EFS with a very favorable hazard ratio, low rates of ILD, but very curious off the bat what your initial thoughts are. I'll start with you, Dr. Mahtani.
So thank you for taking us through the study design and some of the key endpoints. It's very nice to see this highly effective antibody drug conjugate now move up to the early stage setting. But with this data, I think questions emerge. It's clear that the drug is active across the continuum in the neoadjuvant setting, in the adjuvant setting, as we'll talk about DB05, and of course in the metastatic setting. But now we have questions about where to introduce this therapy, this really effective therapy, and who needs treatment preoperatively, who can we perhaps give it to as more of a salvage therapy after with the presence of residual disease. These are questions that we're all going to be grappling with, and I'm sure discussing here today.
Yeah, exactly. Dr. Mamounas, as a surgeon, what are your thoughts about all of this data coming out in the early stage setting?
Clearly, this is exciting because obviously pathological complete response is an endpoint that we really value as surgeons, not both in the breast, but more importantly, even in the axilla. Because it allows us for de-escalation of axillary therapy, both surgically and more recently, even from a radiotherapy standpoint, with the results of the P51 trial that were presented and published last year. So this is exciting. The pathological complete response rates were pretty high. Historically, I mean, if we look back, I mean, it's about what we have expected with a regimen like TCHP. In the control arm, in the trial, the rate is a little bit lower than we have expected, not much. And one sort of question I have in my head is that because of the dose-dense part of the therapy is whether the shorter duration of that chemotherapy in that arm maybe have missed a little bit on the PCR rate, because sometimes PCR is also a matter of time. So, but be that as it may, I mean, it's not to take away from the fact that the PCR rate of 67% is pretty high.
Absolutely.
And that's something we definitely, as surgeons, look very importantly.